should have potential to reduce symptoms and develop coping skills if stressor lies outside the control of the client. Intermediate goals treatment focus on transferring progress already made to a different setting relationship. Anything that builds up a short-term goal. Long-term goals. Implications of change in deeply ingrained patterns and responses. Deep intrapsychic conflicts may be resolved. Relationship between level of function and goals. The lower the client's level of function, the more specific the goals must be. High functioning, the goals may be general. Reality testing differentiates low functioning from moderate functioning. Meeting role obligations differentiate moderate functioning from high functioning. Selecting appropriate intervention. Efficient and effective help for the client is objective. Techniques should be selected that provide the greatest reduction in symptoms, largest increase in function, and most reduction in stress. Person-centered techniques for use with functioning, for use with disorders involving self-esteem, confidence, and health in both settings. Techniques, positive regard, empathy, reflection, support, clarification, open-ended, modeling, report building. Behavioral therapy targets dysfunctional behaviors, works by altering actions. If the stimulated interrupts behaviors, use behavioral. For use with low to moderate functioning, eating, conduct disorders, substance, impulse, conflict, phobia, sexual, suicidal, relapse, some sleep. When used with cognitive, helpful for depression, anxiety, early personality. Techniques, baseline, contract, diaries, aversion, consequences, reinforcement schedule. Techniques, baseline, contract, diaries, aversion, consequences, reinforcement schedules, incompatible alternatives, flooding, in vivo biofeedback, relaxation, role play, modeling, assertiveness, token, activity schedule. Tracking improvement, self-report, review of data, compliance with treatment, appointments, referrals, lessening of symptoms, improvement of functioning, assessing information from individual providers. Cognitive dysfunction. When symptoms are described in terms of cognitive dysfunction, the need for a cognitive technique is indicated. Rational emotive therapy, useful for the treatment of depression, anxiety, mild situational disorders, and bulimia. Cognitive techniques are contraindicated when family has a history of bipolar, schizophrenia, cognitive disorder, or mental retardation. Cognitive techniques, analysis of dysfunctional thinking, patterns, cognitive restructuring, hypothesis testing, mental emotional imagery, modeling, thought stopping, meditation, self-talk, record of dysfunctional thoughts, diaries, letter writing, grading systems, hourly mood graphs, affirmations, systematic assessment of alternatives, grid evaluation. Existential psychotherapy. Goal of changing meaning indicated for high functioning individuals, particularly those with a V code. Those with mild to moderate depression or anxiety help coping with life threatening illnesses, situational concerns, seeking meaning in life. Existential techniques encouraging responsibility, clarification of options, life reviews to discover meaning, development of belief systems, Gestalt counseling, used in combination with cognitive and behavioral approaches, indicated for moderate to higher functioning individuals, good for those with somatic complaints, provides access to feelings with the goal of unblocking. Gestalt often targets anger, grief, anxiety, and depression. Gestalt techniques, unfinished business, giving voice to physical sensation, dream exploration, empty chair, top dog and underdog, exaggeration of feelings and actions, confrontation, and encouragement of awareness of responsibility. Adlerian psychotherapy, lifestyle, resolves from private logic, indicated for those with issues of goals and direction. Parent-child problems, acting out behaviors, career crises, marital concerns, or low self-confidence. Focuses on healthy or unhealthy coping skills. Adlerian techniques, life scripts, guided imagery, empowerment and encouragement, birth order, early recollection, role playing, natural consequences, and development of social interest. Prolonged psychoanalysis, indicated for those with hysteric or phobic disorders. Contraindicated for those with paranoia, borderline personality disorder, and obesity problems. Psychodynamic psychotherapy for high functioning individuals with vehicle disorders, personality disorder, multiple personality disorder. Short term can be beneficial for depression, anxiety, and situational disorders with repeated patterns. Psychodynamic techniques, transference, exploration of dysfunctional patterns, relationship history, discussion of dreams, childhood memories, hypnotherapy, interpersonal psychotherapy, unconscious, conscious interpretation. Adjustment disorders. Objective, symptom relief, symptom relief, improvement of coping skills, and restoration to at least prior functioning. Adjustment techniques, crisis intervention, brief psychodynamic, stress management, short-term interventions are most appropriate. Anxiety disorders, objectives, reduction of anxiety, improved management of stress, development of socialization skills, sense of mastery. Anxiety techniques, physical exam generally indicated, cognitive behavioral and behavioral therapy, in vivo work well except in the case of generalized anxiety disorder, anxiety management, relaxation, guided imagery, stress inoculation, problem solving, progressive muscle relaxation. meditation, biofeedback, and exposure. Most effective therapy is behavioral and approach with a secondary focus on cognition. Group therapy may also be helpful, but individual is most indicated. Ancillary family therapy may be needed as well. Unless the condition is disabling, medication is not generally needed, save in the case of panic disorder and obsessive compulsive disorder. Generalized anxiety disorder, anxiety management program, computer based training, relaxation, antidepressant, or azathirones may be indicated, but do not recommend pharmacological intervention. Panic disorder, panic control treatment, computer based training, relaxation, bibliotherapy, panic education, antidepressants may help. Do not recommend medication. Obsessive compulsive disorder, exposure therapy, anxiety management training, cognitive processing, antidepressants may be indicated. Mood disorders, objective, overall adjustment, mood stabilization, alleviation of depression and mania, enhancement of coping skills, improvement of relationships, and prevention of relapse. Mood disorders, objective, overall adjustment, mood stabilization, alleviation of depression and mania, enhancement of coping skills, improvement of relationships, and prevention of relapse. Depression techniques, cognitive behavior techniques are the most effective. Target overgeneralization, perfectionistic thinking, and tendency to catastrophize. Training in communication skills help in decision making, assertiveness, training, increasing pleasurable activities. Disorders of behavior and impulse control, including eating disorders, sexual disorders, sleep disorders, psychoactive substance use, and other impulse control disorders. Objective, reduction of dysfunctional behavior and acquisition of positive behaviors, behavior change. Emphasis on behavior therapy with a multifaceted approach. Behavior and impulse control techniques, education, measurement of changes, improved communication. Group work can be helpful for those who are resistant to therapy. Medical examination is important in the evaluation. Anorexia and bulimia. Medical assistance and nutritional counseling must be combined with family therapy for a significant change to occur. Hospitalization may be required. Anorexia and bulimia techniques. Behavior approaches to stabilize eating patterns. Insight-oriented psychotherapy follows stabilization. Anorexia. More serious may be present. Bulimia. Insight-oriented focus on body image, self-esteem, and behavioral therapy. Hospitalization can be handled on an outpatient basis. Interpersonal therapy, therapy groups, and computer-based training and behavioral weight loss are appropriate. Sleep disorders, insomnia, stimulus control therapy, sleep restriction therapy, relaxation training, CBT, benzodiazepines, zolpidem, and antidepressants may be effective. Do not recommend medication. Disorders combining physical and psychological factors. Objectives: reduce somatization, constructive expression of feelings, stress management, improve socialization, relaxation, positive use of leisure time, somatoform techniques, physical examination should be Individual therapy is the primary mode. Family therapy may help. Holistic approach with cognitive, behavior, and affective therapy combine the most effective modalities. Personality disorders. Objectives: improvement in social and occupational functioning, increased communication skills, raised self-esteem, enhancement of coping skills, developing a sense of responsibility, long-term modification of underlying dysfunctional personality patterns. Personality techniques. Individual therapy is primary with family therapy accompanied with improvement. Group therapy may be helpful. Psychodynamic approaches are generally used to promote changes in relationships. Cognitive interventions may be used. Medication is rare. Disorder involving loss of contact with reality. The objective: restoration of contact with reality, enhancement of coping mechanisms, maximizing adjustment to the disorder, relapse prevention, providing assistance to family members, working through appropriate care-related decisions, loss of contact techniques, target symptom elimination or reduction. Individual therapy is the usual mode. Hypnotherapy for amnesia. Psychodynamics for multiple personalities. Behavioral therapy for developing coping mechanisms and stress management. Group therapy is not generally indicated. Schizophrenia. Behavioral therapy, social learning programs, family education, social skills training, vocational rehabilitation. Antipsychotics may be helpful, do not recommend medication. Sexual disorders must rule out underlying mental health conditions such as anxiety disorder or depression. Biochemical or medication induced explanations should be explored. Orgasmic disorders in women. Cognitive behavioral approaches focus on anxiety reduction and attitude change. Increasing positive feelings and frequency of orgasms when non-orgasmic symptoms are rooted in traumatic experiences. Insight oriented are indicated. Dyspareunia. Behavior therapy may employ systematic desensitization, sensate focus, imagery techniques, cognitive restructuring, relationship intervention, supported psychotherapy, lubrication assistance. Surgery may be necessary. Do not recommend treatment. Vaginist relaxation, desensitization, guided fantasy, self-control activities, supportive psychotherapy, Kegel. Premature ejaculation, challenging self-defeating cognitions, establishing cooperative partner relationships, behavior intervention, start and stop therapy. Antidepressants may be prescribed, do not recommend medication. Erectile dysfunction, behavioral therapy targeting performance anxiety, cognitive therapy focused on covering scripts, individual therapy, systematic desensitization, learning non-intercourse sexual techniques, sensate focus, hypoactive sexual desire, masturbatory training, male orgasmic disorder, genital stimulation, paraphilia, cognitive behavioral therapy, aversive conditioning, treatment of children. Two methods are considered effective: insight-oriented approaches and behavior-based approaches. Insight for children, the focus is on feelings within experiences. Play therapy, Adlerian therapy, behavior for children, rewards, consequences, reinforcement, behavior medication, treatment of adolescents. Three techniques are considered the most useful: reality therapy, peer culture groups, social skill training. In reality therapy, use of contract and success failure identity concepts may provide helpful therapeutic consideration. Attention deficit hyperactivity disorder. Objective: increasing child's ability to learn and manage impulses. ADHD techniques. Focus primarily on behavior techniques. Enhancing learning environment through reduction of distractions. Training teachers. Instruction on time management, stress management, and relaxation techniques. Oppositional defiant disorder and conduct disorder. Primary treatment setting will most likely be a residential treatment program, day program, or combined school and community facilities. Oppositional defiance disorder and conduct disorder techniques focus on consequences, reinforcement, or rewards, methods that delay impulses by using cognitive strategies such as stop, listen, think, and anger management. Elimination disorders focus on symptom through behavioral approaches, dry bed techniques. Modalities: for the purposes of the exam, only three modalities exist: individual, family, and group. Determine what a client's most important need is and use the technique and modality that best fits that need. Individual therapy. Recommended for clients who have little connection with others, withdrawn, highly anxious, or introverted. If the client is suspicious, antisocial, hostile, or disruptive, individual therapy is better than group therapy. Those who do not deal with ambiguity well, those looking for independence and individualization, difficulties with intimacy are indicated for individual. Group therapy. Clients who need reality testing and group feedback. Recommended for those who may feel stigmatized, scapegoated by individual therapy for interpersonal behavioral concerns, anxious clients who experience authority concern benefits, as well as those who give the therapist excessive power. Family therapy. For families with severe pathology but experiencing communication difficulties within the family structure. When intergenerational conflict arises, when more than one family member needs help. And that is an overview of the theories and techniques for the